All right, we'll go ahead and get started with our last faculty presentation for the AMSSM Ultrasound Case Series for the year. So I have the pleasure to introduce Dr. Joel Jaeger. He's originally from Ottawa, Illinois. He graduated from the Chicago College of Osteopathic Medicine in 2014. This was then followed by a family medicine residency at the Community Health Network in Indianapolis, Indiana in 2017, and then a primary care sports medicine fellowship at the South Bend Notre Dame Sports Medicine Fellowship in 2018. He currently is the medical director for the sports medicine at Major Health Partners in Shelbyville, Indiana. He serves as a team physician for over 5 high schools in the Shelby County, Indiana area. He does have an RMSK certification, and in addition, he's going to be helping out with the AMSSM regional ultrasound course in South Bend, which is going to be next month. So just a plug for that as well too. And today he's going to be giving us a presentation on a volar finger ganglion cyst.
All right. Well, good morning, and thank you, Dr. Shaw, for that introduction and the opportunity to kind of present this case. So again, yeah, I'm Dr. Joel Jaeger, and going to be presenting this case on a flexor tendon sheath ganglion cyst coming to you from Shelbyville, Indiana. So just to start off, I don't have any relationships to disclose. Okay. So all right. So yeah, we're gonna go over this flexor tendon sheath ganglion cyst. Again, I have nothing to disclose, just to go through some objectives for what we're going to do with this talk. So basically, the point of this talk, we're going to go through a diagnostic protocol of the volar finger. Along the way, we're going to discuss pertinent anatomy and also some of the nuances to how this anatomy looks under ultrasound. And then at the end of we are going to review a diagnostic ultrasound report. So the way I want to start off with this, we're just going to jump into the case and how this patient presented. This was a 63-year-old female who came to the office. She was having some painful catching of her right ring finger and left middle finger. She'd had some symptoms of catching in these fingers that had kind of gradually progressed over the last 3 to 4 months. Occasionally, she has to force her finger open to kind of pull it when it's kind of triggering. She has some achy pains with it, but when she gets that catching, it can be pretty sharp for her. She does have a history of being diagnosed with trigger finger in the past, and she had had some flexor tendon sheath injections from another provider that were done 9 months before, which she said gave her significant relief from these. Her symptoms kind of gradually returned, like I said, about 3 to 4 months ago. Of note, there have been no kind of injuries for this, and she hasn't been diagnosed with any kind of rheumatologic diseases. So going and doing a physical exam, taking a look at her hand, kind of an inspection. We don't see anything abnormal with any kind of masses or anything that was over the volar aspect of like her MCP joint. She does have full range of motion, but she's pretty cautious to do it. She really, when that catching hits, it's pretty painful for her, so she was cautious with it. As far as looking like with palpation, she does have some tenderness kind of right over the metacarpal heads and the MCP joints on the volar aspect for the fingers that are affecting her. So her left middle and her right ring finger. The rest of the exam, she didn't have any kind of tenderness. Sensation with she's neurologically intact, and I'm able to reproduce. I put a little bit of pressure kind of over these areas where she's tender and passively flexing, extending her fingers. She wasn't fully triggering, but you could feel a little bit of a catch as the tendons were kind of translating through. I was able to access some X-rays that she had done and compare those kind of before the visit, or kind of look at those before the visit. These were the ones that other provider had ordered, and on these X-rays, it kind of were they're from about a year prior to when I saw her. She had a little bit of degenerative changes with some arthritis, but otherwise, I felt they were kind of unremarkable. Things that when I'm kind of going in preparing to do it regards to doing like an ultrasound comparing to this other imaging, obviously we want to look at what was seen on, say, the previous radiographs. Were there any kind of fractures? Do they have impressive like arthritic changes? But part of what I'm also kind of doing, is there anything unusual that I need to kind of pay attention to, or maybe to dedicate something to look at and just give you another clue on things you might want to include in your ultrasound exam as you're going forward. So that's something kind of for some younger learners, kind of referencing some of the other imaging that's done before you're doing an exam. I think can sometimes be helpful as you're kind of building and trying to get better with doing diagnostic ultrasounds. So she's coming in. We're going to go and kind of do an ultrasound diagnostic and take a look at her hand. And the expectation, we're probably going to be leading to an injection. She was kind of pretty clear that was her goal for this visit, was to go in. So as far as preparing to an ultrasound of the hand, not everyone has like all the latest ultrasound machine or all of the probes that they can have. If we're going to start doing some hand ultrasound as part of your practice, I do recommend going towards more of those high frequency probes, because some of those smaller structures are just much easier to visualize. Whether you're using a hockey stick or some of the other small frequency probes, I have a linear 1022 that I use. I feel like that is the main probe that I'm using when I'm doing any kind of hand or finger ultrasound. To do this volar exam, patient's going to be seated, could be either be in a chair, on the end of an exam table, or on a stool. And then I have their palm, their hand placed on a Mayo stand with a towel. You can use a table, but then palm up. I tend to adjust the height just so it's ergonomically a little bit easier on their shoulder, away from keeping them in that position for a little bit. Something I think is worth kind of commenting for hand ultrasound. I hear water bath mentioned a lot. I don't know a lot of people that use it clinically, but that is an option that you can do. And the nice thing about the water bath is kind of you're surrounding all the anatomy, so it's easier to kind of do some lighter pressure or step offs, and it's really helps you get a good picture. Typically what I use is I tend to use ultrasound gel, and I'm going to just add a extra gel here so I can tend to float my probe for different areas. And I think that's going to really help, especially when you're starting to try to visualize some of these structures really well. This is, I added these two slides on here because this is something I'm going to kind of come back to this point later in the case. I think with all these different cases that are presented through AMSSM, I think there's a ton of great knowledge that's been put into them. And I think with a lot of when I'm trying to learn things, I'm always trying to pick up a little, like some pieces of wisdom as far as application of what we're trying to use. And as I've been going through learning ultrasound, one of the things, a quote from one of my med school professors, Dr. Sarekia, he used to always say this in our physical exam classes, where he'd say, the eyes don't see what the brain doesn't know. And I think ultrasound, that is so true. So you really have to know the anatomy that you're looking at, but also the nuances to the anatomy to be able to see these things, so your brain actually recognizes it when we're seeing it. And that's how you're going to start to develop, see these patterns and recognize these things when they're on the screen. Another thing, as going through fellowship, one of my mentors there, Dr. Chris Jordan, he was always kind of saying, know normal well, so you'll recognize when abnormal presents itself. So that kind of goes back to knowing the anatomy. One of the things I would say I would take a step further is also knowing the characteristics of common pathology well, and what delineates those things can be something pretty helpful for when you recognize unexpected pathology. So, I think we all use Jacobson's as a really good resource for developing our ultrasound. And I think his second chapter for the concepts on, or pathology concepts, I think is actually a great place for a lot of people to start and just kind of learn those things well, so they're prepared for unexpected things when they're doing their exams. Anyway, getting back to doing the ultrasound exam, the way I tend to organize my protocol, I tend to kind of just think about more about the anatomy and then go through the different anatomy structures as a checklist in my mind. So what I will start off with is the flexor tendons. So we're looking at our flexor digitorum profundus and the superficialis. I'm also going to look at the annular pulleys that are overlying those and holding those in place. We want to take a look at our volar plate and the collateral ligaments that are going to be sitting just deep to those flexor tendons. And then while we're in this area, we're also going to want to take a look at our the joints, our MCP, PIP, and DIP. And then we wouldn't want to miss any kind of cortical step-offs or any kind of other bony pathology. And I think this is something that should always kind of be included in a protocol. You want to just kind of train your mind to catch these things, because it's something you don't want to miss. So reviewing the anatomy in this area, I'm going to kind of start with the flexor tendons. So the flexor tendons, we're kind of coming right over our fingers on the volar surface here. On ultrasound, they look like these hyperechoic fibular structures that are immediately like superficial to our bony structures in the hand. And with that fibular pattern, with them sitting right on top of each other, and for the majority of their length, they're parallel to each other, it's really hard to kind of distinguish them from each other. So the way that we do that is there's a dynamic test we can do. To understand the dynamic test, you kind of have to understand the anatomy on how these attach or insert on their bony structures. So if we're starting in the palm and then coming distally down into the finger, I'll start with the profundus because it's the simpler tendon. It kind of just stays along the bone, extends over the PIP, past the DIP, and inserts on the distal phalanx. Overlying it, we can see the superficialis tendon, and it's coming down, and then it will start to split into these two bundles, and they will kind of come off to the sides and start to come in this kind of parasagittal plane to come around the profundus, where they're going to insert on the middle phalanx. Here's a good picture of it kind of here, and this space in where the profundus is going to come through, that's called our Camper's chiasm. So that's it's kind of a complicated structure, and sometimes that can be a challenging thing to kind of put in your mind three-dimensionally as you're looking at these tendons. So that's something we're going to come back to. I think the big point with that is because the profundus is the only one that extends past the DIP, that allows us to understand why this dynamic test I'm going to show you works so well, or works well to differentiate these. So here, this is actually a little bit of a zoomed out view, just kind of for the sake of this talk. I used uh, my mediums probe, where I used an ML615 for this to kind of just zoom out to show you. And what I'm doing is I have the patient place their hands palm up. I've got my probe in one hand. On the other hand, I have my index finger over their DIP joint, and I'm using my thumb on the tip of that finger to passively flex and extend the DIP. And when we do that, we're able to see that flexor digitorum profundus kind of translate right underneath the superficialis. So that's kind of a view of that happening with this zoomed out view. As we kind of mentioned before, this is something that's going to be more done with probably a smaller probe that we're using more of those higher frequency probes. So here's a video that kind of demonstrates this. So again, kind of doing the same kind of dynamic test and just looking at these patterns. As I pause this, you can see with that fibular pattern of the two tendons, it's kind of hard to differentiate those two. So once you add a little bit of movement, then it's easy to separate them out. This is something that I think, especially when you're starting out with ultrasounding the hand with all these small structures, adding a little movement dynamic test is really helpful to help your eye kind of catch these structures when sometimes they can be a little harder to visualize. So anyway, that is the dynamic test. Coming back to those tendons, I went over kind of how the superficialis comes around the profundus with that Camper's chiasm and inserts on the middle phalanx. This is something we're also going to look to. So when I'm looking at my tendons, now that we've kind of separated them out, we've kind of looked at that fibular pattern. As you're scanning along the length, we're looking for any kind of like hypoechoic change. We want to start looking at where they're going to go down and insert distally. So we're going to want to kind of keep this in mind, how this is coming around to the sides. And we're going to want to, it can be hard to visualize in just a long axis view. So to kind of see where this transition comes with the superficialis coming around the profundus, I think a short axis view is really helpful for this. So we're going to kind of take a look at that now. Again, here's another zoomed out long axis view. Looking down on this end, you can see I have here's our superficialis and here's our profundus. But that superficialis right here, just a little proximal to our PIP, it starts to thin out a little bit, and it becomes a little bit hypoechoic. We have a little bit of anisotropy here because this is starting to go out of plane as it's coming around the profundus. And if we follow that along its length, it disappears over the middle phalanx, and we can see our profundus coming up along to insert on the DIP. One thing I want to point out with this view also, and this is something to keep in mind when you're assessing pulleys, and maybe jumping ahead a little bit, but the pulleys and the flexor tendons kind of work together. What we can see here is you can see how the profundus, the contour of it kind of mirrors the contour of the phalanx. So we know that this A4 pulley is working because we don't have any bowstringing. So this would be something else we'd be looking for when we're taking a look at the flexor tendons to see that we don't have any bowstringing where that comes out kind of straight across. Or kind of a little more taut, like say a bowstring. The other thing we were assessing for is kind of underneath this tendon. We're looking for any kind of gap with fluid. Also looking to see if this is compressible. So that's another kind of commenting on that light touch I was referencing earlier with using a lot of gel or that water bath, that you can kind of float this, because if we're compressing a little too hard, we might artificially stabilize that tendon when the pulley is absent and not doing it. So something to keep in mind when you're doing that assessment. Now, getting back to that superficialis camper's chiasm. A couple of these videos and pictures, we had a little issue getting them off my ultrasound machine, so there's gonna be a couple of things during this talk. The quality is just a little more grainy. Apologize for that. What we can see here is this is a short axis view. Here is our profundus tendon, and up here we can see our superficialis. You can almost see this little kind of hypocoel kind of cleft here, where it's already kind of to start to separate out. Now, as I'm doing this video, I'm doing that same dynamic test that we kind of talked about, where I'm kind of repetitively just passively flexing and extending the DIP joint. And you can see as I translate down, those bands of the superficialis kind of rotate to where they're almost sliding underneath the profundus. So I'm going to just do that one more time. The other thing you can see is that profundus is coming, it appears almost to be more superficial, because now the superficialis is no longer over the top of it. So that's something that I would encourage you to kind of look at, to kind of learn that anatomy and recognize those well. But that dynamic test, I think, is really helpful to see that. Okay. So we've kind of taken a look at our flexor tendons, and now it's time. I always go to look at the pulleys next, because they tend to work in tandem, as I was referencing earlier. So to look at the pulleys under ultrasound, these are kind of a fibrous band that's surrounding the tendon. The way it appears on ultrasound, I think it's best to kind of see them on a long axis view, where they have a kind of a trilaminar appearance. If you think about it almost like I guess I think of a sandwich when I look at this, where the two slices of bread would be the hyperechoic kind of texture of the pulley, and then the contents of the sandwich in the middle is kind of that hypoechoic presence. We'll see a picture of that in just a second. You can also take a look at the short axis to where it looks like a hypoechoic kind of band. So we'll kind of talk about that. I included all 5 of the annular pulleys in this talk, more for completeness. I would say if you're going to do this for a ultrasound protocol, I really think the A1 and the A2 are the main ones that I would include for a complete exam. When I'm doing this, they're the ones that tend to have more pathology. When I've looked at, there is some literature talking about A3 and A4 pathology, specifically in rock wall climbers, but I would say that's much more of a uncommon injury that I would probably assess more based on a clinical suspicion. The A5 I also included here. That's a very tricky one to try to see because of how small it is. And when I was looking for pathology in that area, there'd be other things I think I'd be looking for, more like a tendon rupture, avulsion with a jersey finger, but included that just the same. Going up to this anatomy picture, looking at our A1 and our A3, they're very similar. They're at the MCP and the PIP joint, kind of respectively. So the A1 pulley, when I'm looking for it over the metacarpal side of the MCP joint, sometimes I feel like it's just a little more proximal than I expected it to be. So I would encourage people to kind of translate a little more up and down to just kind of see a little more of that tendon to try to visualize it well. And then as we kind of slide up to go look at our A2 pulley, we can see this is right over our proximal phalange shaft. Thing to note about the A2 pulley, it tends to be a little bit thicker, more on the distal aspect of it. So if you feel like you have a hard time seeing it when you're first starting, go a little more distally to try to see it a little bit better. And then you can also see kind of where the A3, I think of this like a small version of the A1, where it's on the proximal side of the joint. Of note, the A5 is on the distal side of the joint if you're trying to look for that. And then when you're going to look for the A4, it's as we look at a picture of it, it looks very similar to the A2, with it being over that middle phalanx shaft. Okay, so here is a longitude or at a long axis view of that A1 pulley, and here's that trilaminar appearance that I was talking about. So you can see that hyperechoic, the top, the hyperechoic bottom with that hypoechoic kind of substance in between. When you're first looking for these, sometimes it almost blends in a little bit with the fibular pattern of the flexor tendons. So this is something where that dynamic exam can be helpful. Now, if you're looking for the A1, that the way I describe the dynamic exam is more going to get the profundus to translate. So for this test, you're going to want to do more flexion, passive flexion extension at the PIP joint. So you're getting both of the tendons to translate under here, but that little bit of motion can help make that A1 pulley more apparent for you. These are a couple of those pictures. Sorry, they're a little bit more grainy, but I think we can see what we're trying to see from them on this view. These are short axis views of the A1 pulley. If we're looking over to the left side of the screen, you can see this hypoechoic, almost arch, thins out a little bit over the top, but you can still very plainly see it coming over the tendons, and it looks fairly symmetric. And it's much more thicker here. Going to the right side of the screen, you can see where I've translated distally past the A1 pulley. And again, you see maybe a little bit of some hypoechoic change. It's not contiguous across the whole tendon, and it's much thinner. So if you're kind of seeing it, it's very thin. If it does come across, possible suspicion, do we have like a tendinosynovitis or things? So you want to kind of scan up and down where you can see these thickened areas to try to visualize that better. One thing I forgot to mention, if we're talking about the pulleys, for pathologic view, we're going to look for some pathologic thickening of these or any kind of like a hypoechoic kind of presence or kind of fluid that could be surrounding the pulleys. Also, some dynamic testing, you can actually see visualize triggering under these when you do those dynamic tests. Okay, going on here, here's kind of what our A2 looks like. So again, we're over the proximal phalanx. We can see that here. We have our flexor tendons, and then that trilaminar appearance to the pulley. Again, this is the left side of the image is the distal end, and you can see where that A2 pulley is a little bit thicker than if you go a little more proximal. So that's just how we visualize A2. A3 again is kind of similar to the A1, but just looks a little bit smaller. But again, on the proximal side of the PIP joint. Our A4 again looks very similar to the A2, kind of sitting right over the middle phalanx shaft. And then here's our A5, which this one is pretty tricky to try to isolate. Again, I wouldn't include this in our complete exam. If you're looking for pathology in this area, I would probably be more interested in this profundus tendon, looking for a rupture here, any retraction that you could see for like a jersey finger, or if there was an avulsion injury of the distal phalanx. Okay, so now moving on to our volar plate and our collateral ligaments. So these are going to be deep to our flexor tendons, and they're going to be sitting over our MCP and IP joints. This is kind of a tough kind of fibrous ligamentous structure that is incorporated into the capsule. So it has kind of a ligamentous attachment proximally with a capsular attachment distally. This is going to appear as a hyperechoic structure overlying the joint space. It's going to be deep to the flexor tendons. If you're trying to evaluate this, say you have a hyperextension trauma, you're concerned for, say, like a volar plate tear, things you're going to be looking for is if it's a tear within the volar plate itself, there will be a little bit of a hypoechoic change you will see kind of through the volar plate. The other thing we'd be thinking about would be an avulsion injury, where it would just avulse typically off the distal end, where you say if it was at the PIP, you would be pulling off the base of the middle phalanx. Something else to keep in mind as far as a differential, if you do see something that almost is similar to avulsion with kind of that increased kind of bony signal at the end, but there's no history of trauma, that might be a tip off. This could be an enthesopathy. Those are things that can be more commonly seen, say, in patients with psoriatic arthritis or a seronegative kind of arthropathy. So those might kind of tip you to kind of, you might be thinking more of a rheumatologic cause. So to look at that volar plate, here we are over the PIP, middle phalanx, and you can see this structure here. That is our volar plate. We have our flexor tendons over the top. Here's our ligamentous attachment with the capsular attachment up here. This is where classically where we'd be looking for that avulsion. Now you can see our joint space kind of right underneath it as this hypoechoic space. Again, looking for little subtle things, adding a little movement dynamic test can be helpful. If we were looking for, say, a hypoechoic change with a tear across the substance of this volar plate, a little compression and distraction can be helpful. That compression can kind of compress some of the joint fluid to occupy that defect and might make that tear a little more prominent to you. I wouldn't, from the videos I've seen of this, I haven't actually done one of these in my clinic, because typically uh, when I'm seeing the avulsion and treating that, I tend to just kind of jump to treating the patient. But when we're looking for those things, that little bit of movement can help your eye catch it to make it so much easier to visualize the pathology. I'm just going to back up just real quick here, just kind of briefly talk about the collateral ligaments. The collateral ligaments are kind of coming almost this, I guess you could say, kind of that parasagittal plane as well, where it's a little bit oblique. So if you're concerned about, say, like a valgus or varus injury, and you have some laxity with valgus or varus testing, and you want to evaluate these collateral ligaments, you're not going to want to go parallel to the bony structures. You want to be parallel to the fibrous structures that make up those collateral ligaments. So you want to be able to adjust your probe appropriately. Now here, I'm just going to pause this. Here we have the base of our middle phalanx, and then the head of our proximal phalanx. Sorry about this grainy picture. Here is the radial collateral ligament. So this is something where I'm doing a little bit of a dynamic test with a valgus or varus, again, using kind of my index finger and thumb to kind of create that. And I think right here, we can kind of see that coming all the way up. And I didn't see any kind of step offs or any kind of joint space gapping. So, okay. Next on our checklist that I'd be going through, I'd be wanting to look at the joints themselves. So when we're kind of assessing joints in this area, a lot of time for osteoarthritis with any joint, you're kind of looking for a little bit of thinning of the cartilage. But one of the main things I think we need to assess here is kind of looking at our joint recesses, looking for any kind of distension of fluid. Looking for, say, like a rheumatologic cause. We say if we had a septic joint or something, this is also an area where we would see that. If you're looking in those joint recesses, we'd be looking for like an anechoic change. Sometimes we get more of a mixed echogenicity. So is it a thicker fluid going along with a septic joint? Is it synovial hypertrophy? Those would be things we'd be looking for in that recess. I put this lateral X-ray up here because I thought it was a really good way to just kind of visualize these joint recesses. We kind of get a little bit of a picture in our mind, kind of the shape we're going to be looking for of that bony cortex when we are looking for the recess under the ultrasound. Going back to kind of the recess, one of the ways, if we are worried about that mixed echogenicity and some synovial hypertrophy, throwing our power Doppler on there to look for some hyperemia can help us kind of to observe, to see the hyperemia, and then kind of help us make us concerned for, say, synovitis affecting this joint. Other things to look for would be also just the texture of that cortex. Is it nice and smooth, or do we tend to have some erosions in the subadjacent bone? Do we have osteophytes? Those are other things we're looking at. And just another comment over here, this is getting even a little bit away from the joint, but as you're doing these tests, always kind of going back and looking at the cortex of the bone, just making sure we're not missing any kind of cortical step-offs or, say, a hematoma around this area that would suggest like or a periosteal reaction that'd be suggesting like a fracture. Here are those some pictures just showing those joint recesses where we would be looking for some of that fluid to build up. So this is our MCP joint. This is the proximal side where we have our joint recess here. And then same joint, I just went to kind of visualize the distal aspect. And those are the areas we'd be looking for those recesses. Okay, so with looking at all this anatomy, I was reviewing just some ultrasound protocols as I was going through this talk and kind of looking at a lot of just like these kind of some standard protocols throughout the body. There's a lot of regions that have very clear standard protocols. But with looking specifically, like even with AMSSM and the AIUM, when you look at hand and wrist, the very set protocols tend to be more for the wrist for specific things. The finger is a little more, you look at areas based on kind of clinical suspicion. You look where you think it is kind of warranted. And I do think that's appropriate. The one thing I would caution people about, though, is just falling into the trap of just going to look at one thing and not expanding their view to look along entire lengths of some of the structures, and then also just going through your checklist to look at these things. That kind of goes along with also knowing normal and knowing when unexpected things pop up, because we can miss things if we are just jumping and going straight to the pathology and not taking our time to kind of really evaluate this tissue. The reason I bring that up is because in this case, the case that I'm presenting to you is a 63-year-old lady who comes in with a very classic presentation of trigger finger. She's been previously diagnosed with trigger finger. She had injections for trigger finger that resolved her symptoms. So it'd be very easy to just go in and just do a trigger finger injection for her if you say she was someone who came in during a busy clinic and we thought this was a reasonable treatment plan and we went to go do an injection. When I went in there, I started looking and then I saw this. So this is kind of knowing that anatomy, knowing what you should and shouldn't see. So this is a flexor tendon ganglion cyst that I was not expecting. So we kind of look on there and I see this big hypoechoic cyst, and that kind of tipped me off. Okay, we're gonna expand and look even further to make sure we didn't miss anything. This was just a little bit proximal to our A1 pulley. So had we stayed a little distal, we could have missed this. I kind of have a picture of this on both views. Just kind of a little briefly, something about a flexor tendon ganglion cyst. The flexor tendon is a pretty uncommon source for a ganglion cyst, even though ganglion cysts in of themselves are pretty common within the wrist and fingers. Typically, these look as a single simple cyst. They tend to be associated with autoimmune diseases. And if we're with just aspiration, their recurrence rate tends to be about 60%. So with this in mind, kind of thinking about this clearly looks very much like just a simple cystic structure. We didn't have any kind of flow on power Doppler with this. One of the things I did, I wanted to just kind of going through looking for some different characteristics. I wanted to make sure that this, I was looking to, there's a dynamic exam showing that this is not attached or adhered to the tendons at all. So this is definitely coming off of the sheath. This video to kind of visualize that. So seeing this, we kind of decided to treat this clinically as a ganglion cyst. So I hadn't confirmed it was truly a ganglion yet. So I discussed this with the patient and talked about doing an ultrasound guided aspiration. She was agreeable to this. And I was able to aspirate what looked like thick ganglion fluid. After I was able to aspirate this, when I went and repeated my physical exam, I didn't really have that little bit of catch when I was flexing and extending her fingers. So this was the source of her triggering. But we didn't want this cyst to recur, so I ended up re-cleaning the skin, and I went ahead and did an ultrasound guided injection for this cyst. So one of the things that kind of begs the question here, this patient presented sounded very similar to the case she had before. She had injections done before, but she'd never been told about this cyst. I was actually able to reach out. I found the previous ultrasound study and what was done previously, and there were only short axis views to see an injection done that was in an out of plane approach. So with that, it kind of begs the question, is this cyst coming from a rare complication of there being a compromise of the sheath, or was this the problem we had before, or was this something that was seen and not recognized? And in no way am I trying to call someone out or throw someone under the bus, but the point of all these videos to improve our ultrasound protocols is to make sure that we're not missing these things, and we don't want to be the person who does miss them. So I'm just using this kind of demonstrate the order and method behind doing these things is probably the most important piece, and staying consistent and rigid with those, and always scanning a little bit wider view, and then hitting all of your check marks can't be understated. So now that we've kind of gone through this case, we looked at our ultrasound images, we need to do a little editorial on what did we see. So when you're writing an ultrasound report, we need to start with just kind of the basic things that we need to include in every ultrasound report. First of all, why did we do it? What were our indications for going in to look at this? Um, how did we do it? What did we use to take a look at these areas? So we did long and short axis views with our linear array high frequency probe. And what other information do we have looking at this? What kind of imaging do we have before going into it? We compared to that 3-view hand x-ray that was done previously. A lot of times I'm getting sent some diagnostics from one of our upper extremity orthopedic surgeons, or I'll get sent that from other providers as well. And then I always just kind of include referring provider in the report. Next, we're going to want to go in through and look at, or and kind of describe all the findings. I think when we look at all these different videos that are done on AMSSM for ultrasound, I think there's a lot of variance to the different findings. I think the best way to organize these is a way that fits your checklist in your mind, and it's a way that you're not going to miss anything. So everyone has a little bit of variance. Mine is kind of breaking these up into the different areas of anatomy and kind of breaking them up into almost categories and going through each category. And that's what works for me. So here I just have a brief description on all the things we kind of looked at, looking at the fibular pattern, some of the dynamic exam, following the tendons up to their distal insertion. And this is kind of one of those do what you say, and say what you do. So if you're going to put these in your kind of your default exams or reports to write them up, we should make sure we're going through and looking every time. In regards to the pulleys, I kind of just include the A1 and A2, commenting on if there's any kind of pathologic thickening or fluid surrounding them, and also commenting if we have any bowstringing that we might be looking for. A little description about our volar plate, commenting on if there was any kind of hypocoque defect, any that we could express with the dynamic test, and also comment on any kind of cortical change with that enthesophyte or possible avulsion fracture, and then kind of some of the things we talked about with looking at the joint recesses and the bony cortex kind of texture. And I always kind of include, if it's not something that fits into those categories, there's this other category where I could put something, and this is a perfect example of that, something unusual I didn't expect goes in the other. And at the end, our impression, kind of where we're making our diagnosis for that. So kind of a nice, here's all the things that I saw in summary. This is what we are dealing with. Here are my citations. And thanks for your time. I'd like to open up for any questions.
All right, Joel, thank you so much for that detailed presentation, especially the anatomy and kind of pathology for the volar finger. Just just see if there's kind of any questions or comments going through. Otherwise, I just had a few that I was going to make. As you had mentioned, kind of the main thing we try to focus on, for these presentations is going to be the protocol, which you kind of had a detailed overview for the volar finger. The only thing occasionally, I think probably just more if your kind of clinical exam kind of points towards this, is you can evaluate sometimes occasionally the dorsal surface as well too, just with the extensor tendons, just in
Mm-hmm.
case the sagittal band, if you have a rupture of that, and the patients are kind of getting clicking or locking from that. But
Mm-hmm.
honestly, a lot of the time that's just going to be more based, I think, on kind of your clinical exam if it's pointing towards that, or definitely I think probably in the more refractory cases that you've had a patient you've been really treating for a prolonged period of time for a trigger finger, just not really kind of then adding up or getting the successful treatments. That's one other thing that you can look for, or especially in cases that maybe patients have actually had a trigger finger release and they're still having symptoms. That's one other thing you can kind of add into the protocol to
I
potentially
agree
look
with
at.
that. I think that's something I actually kind of keep in my physical exam. I have caught a couple of these, and that is actually something I've seen reference in a couple other of these videos where it's on the differential
Yeah, it's on the
for
differential, obviously.
that.
Not the highest, but just something that, clinically wise, if you feel like you're having some of those symptoms on your exam or your history, maybe potentially then include, for the protocols as well too. I think
Great.
this is just a really good case, just demonstrating once again the utility of the ultrasound being an extension of your history physical exam. and then changing your management, because ultimately, you had mentioned you could easily just do a trigger finger injection for this patient, at the A1 pulley. But that's not even where this pathology was. You were mentioning the ganglion cyst was actually a little bit proximal, to that location. So if you don't really identify this, they may get some temporary relief, but you're going to really actually have to change, where you're performing that injection to go to the site where the cyst is at. And they're not always going to be over those pulley, locations. And so this is just a clear example of the ultrasound kind of really helping to guide you, for management, as well too. And then the last thing I was just going to kind of bring up, which is obviously going to be a little bit more of a broad topic, but is just the idea then of a soft tissue mass, for the finger region. Obviously, ganglion cysts are going to be, probably the most common, that you'll see of the benign soft tissue masses. You
Mhm.
had kind of, alluded to some of the characteristics, of the cyst, that typically it's going to appear obviously anechoic, cystic, oval. Typically, it's going to have no vascularization, which you had kind of mentioned, in your report as well too. The two other things that occasionally I'll see with these, and mention is just the compressibility. Is that obviously sometimes if you're looking at just like a very hypoechoic and thickened pulley, that's still going to be ultimately compressible. Whereas if you have a subtle ganglion cyst, that's going to be a mass that's non-compressible. And then the other factor too is that typically those cysts, which I saw in your images, is that they'll have that posterior acoustic enhancement or increased through transmission, where you'll see deep to the ganglion cyst that it's going to appear more, hyperechoic or bright, underneath the cyst, and that's one way to kind of help to differentiate that this is a true ganglion cyst. I think occasionally the other kind of differential, for these soft tissue masses that occasionally you can get in this area, if patients are being sent for symptoms like this and they do have swelling, would obviously be a giant cell tumor is probably the second one that I'll see in this area. And typically, to kind of differentiate with the giant cell tumor versus a ganglion cyst, those are going to typically appear a little bit more hypoechoic or kind of mixed echogenicity compared to the ganglion cyst. They're typically going to have, they're typically going to be involved with the tendon sheath as well too, which can be very similar to the ganglion cysts. But then the other key for those is that typically with the color Doppler is that they will actually have vascularization, to that area. And then just the last two that I would say to keep on the differential just for soft tissue masses would be just a fibroma or an epidermal, cyst in those areas. But those are all, things just to kind of keep a broad differential just for the soft tissue, masses in the finger. But then as
What?
you, yeah,
Oh, sorry, I didn't mean to want to
no,
interrupt
you're fine.
you. Going along exactly what you're saying, as you're saying, this kind of remind me of another case I had. Not that I'm trying to do another case, but it was a person who had this was more in the wrist, and it was bump on the volar wrist, looked like a ganglion cyst. Went and saw a different provider who tried to aspirate it and was just unable to. And this, I ended up being seen for a second opinion, and kind of like you're saying, kind of going through knowing all those different characteristics of the pathology. And this was a nerve sheath tumor that I
Yeah,
had seen that this person was trying to aspirate, and it's kind
yeah,
of,
yeah,
you got to highlight exactly what you're saying, like, and that's kind of what I was trying to portray with knowing those things. We just don't want to be the person who misses these things. So yeah, kind of looking at these differential and knowing those the the defining characters of common and uncommon pathology is what will save us from those mistakes.
exactly. And obviously, just kind of as you had mentioned, just describe what you see, in the report. And I think if you describe what you see, then you can kind of then go to the pathway of then figuring out potentially what that soft tissue mass is most likely, going to be, rather than I think just initially just going to, hey, this is the finger, this is a soft tissue mass, most common is a ganglion cyst. That's where I think you can kind of start to make mistakes. So just making sure when you're going in your protocol like you had done is just describing what that soft tissue mass looks like, and then typically in the impression, then that's what I'll allude to like you had done is most likely representative of a ganglion cyst in this area. So but yeah, those are the kind of only comments that I have for this case. Otherwise, I don't see any other, questions. So we'll kind of then conclude, the final presentation for the faculty, this year. So appreciate everyone, volunteering for these presentations. I know it's greatly appreciated by, all the learners that go to check these out on the AMSSM YouTube page. So once again, thank you for the presentation, Joel.
Thanks for the opportunity to do it. I appreciate it.